Good evening, namaste, and everyone present here. Myself, Dr. Tshetiz Dahal. I am basically a medical doctor, clinical researcher, and writer. My affiliation is from Ukraine and China, but I belong to India. So the paper, the clinical research, which is based on deep spatio-spatial models for classifying brain tumors in MRI images. The article is published in IJDMSR. So let's start. The abstract goes, a brain tumor is a mass or a cluster of abnormal cells in the brain that has the potential to spread to other tissues nearby and pose a serious threat to the patient's life. So for effective treatment planning, a precise diagnosis is necessary. And the main imaging technique for determining the extent of brain tumor is MRI. So the majority of this increase in deep learning techniques for computer vision applications that may be attributed to the availability of a sizable amount of data for model training and the advancement in model designs that produce better approximations in a supervised environment. So the availability of free data sets with trustworthy annotations has significantly improved the classification of cancers using such deep learning techniques. These techniques often use either 3D models that employ 3D volumetric MRIs or even 2D models that take each slice into account separately. So, however, spatio-temporal models can be used as spatio-spatial models for this job by treating each spatial dimension individually, or by seeing the slices as a succession of images through time. So these models can learn certain spatial and temporal correlation while using less processing power. So this study classifies several types of brain tumors using two spatio-temporal models, RES-Net 2+1D and RES-Net Mixed Convolution. So it was found that both of these models outperformed RES-Net 18, a model that only used 3D convolutions. It was also shown that pre-training the models on a distinct, even unrelated data set before training them for objective of cancer classification enhances performances. So as a result of these studies, pre-trained RES-Net mixed convolution was shown to be the most effective model, achieving a macro F1 score of 0.9345 and a test accuracy of 96.98% while also being the model with the lowest computing cost. So the most common primary brain tumors are oligodendroglioma, astrocytoma, meningioma, pineal gland tumor, optic nerve glioma, craniopharyngioma, pituitary adenoma, Schwann cell tumor, ependyoma, brainstem glioma, and medulloblastoma. I have present before my paper of craniopharyngioma too. So the introduction goes like the growth of abnormal brain cell is known as a brain tumor basically. So based on the rate of growth and likelihood of recurrence following therapy, brain tumors are categorized. So they can be broadly classified into two groups, malignant and benign. Non-cancerous benign tumors spread slowly and are also less likely to come back following therapy. So contrarily, malignant tumors, which are mostly composed of cancer cells, can either locally infiltrate tissues or migrate to other parts of the body through a process known as metastasis. So mutations in glial cells cause malignancy in normal cells, which results in glioma tumors. They make about 80% of total of all malignant tumors and 30% of all brain and central nervous system tumors. So making them the most prevalent forms of astrocytomas, brain or spinal cord tumors. Glioma tumors can have astrocytomas, oligodendrogliomas, or ependymomas as its phenotypic makeup. So I have been provided a short video. You can watch this for a while. It was provided by Cleveland Clinic.
Let's face it, brain tumors are scary. And unfortunately, around 85,000 people in the US face this diagnosis each year. A brain tumor is an abnormal growth or a mass of cells that develops in or around your brain. Brain tumors can be malignant, meaning they're cancerous, or they can be classified as benign, meaning non-cancerous. Doctors aren't exactly sure what causes most brain tumors. Possibilities include a gene mutation, or chromosomal abnormality, or exposure to radiation. Some major warning signs include ongoing severe headaches, especially in the morning, difficulty with balance or coordination, speech difficulties, changes in your personality, bumping into things due to vision loss, seizures, and numbness, weakness, or tingling in one side or part of your body or face. The most common primary brain tumor, or a tumor that starts in the brain, is a meningioma. Most meningioma are benign and are found on the brain's outer surface. You might see a meningioma at the top of the brain or at the base of your skull. Warning signs are similar to those of other brain tumors and include double vision and hearing loss on one side. There are 3 types of meningioma: grade 1 or benign meningioma, which grows slowly; grade 2 or atypical meningioma, which grows more quickly; grade 3 or a malignant meningioma, which grows and spreads rapidly. Most meningioma grow very slowly. In fact, you might confuse tumor symptoms with something else, like the effects of aging. However, even non-cancerous brain tumors can affect your ability to function. Large tumors might press on nerves, blood vessels, and tissue. This can cause related health issues, including a stroke. It can be very frightening or disorienting to suddenly experience the symptoms of a brain tumor. If you notice worrisome warning signs, call your doctor right away. If the symptoms persist and are severe, go to the emergency room. The sooner you seek out life-saving care, the better off you'll be.
Okay, so that was the short video. So now you are clear about the brain tumor. Actually, what is it? So according to the World Health Organization, employs the following grading best methodology to categorize each of these tumors depending on their aggressiveness. So grade 1. These tumors are frequently detected in children and are typically benign tumors, which means they are usually treatable. Grade 2. 3 tumor types fall within the grade 2 category: oligodendrogliomas, oligoastrocytomas, and a combination of both. Adults commonly experience them. All low-grade gliomas have the potential to develop into high-grade tumors over time. Grade 3, anaplastic astrocytomas, anaplastic oligodendrogliomas, and anaplastic oligoastrocytomas. So these are all the examples of grade 3 tumors. They are more sneaky and aggressive than grade 2. Grade 4, glioblastoma multiforme, GBM, another name for grade 4 glioma, is the most aggressive tumor according to the WHO classification. So in general, grades 1 and 2 gliomas are considered low-grade gliomas, LGG, while grade 3 and 4 are known as high-grade glioma, HGG. The LGG are benign tumors and they can be excised using surgical resection. In contrast, HGGs are malignant tumors that are hard to excise by surgical methods because of their extent of nearby tissue invasion. So I will go to show in a figure 1 that shows an example of MRI of LGG and HGG. So you can see in this figure, this is an example of MRI low-grade glioma LGG on the left one and a high-grade glioma HGG on the right. So the glioblastoma multiforme GBM typically has the following types of tissues. I will let you show in figure 2. So this is the tumor core. This is the region of tumor that is the malignant cells that are actually proliferating. Second one is necrosis. The necrotic region is the important distinguishing factor between LGG and GBM4. This is the reason where the cell's tissue are dying or they are dead. Perifocal oedema. The swelling of the brain is caused by fluid that build up around the tumor core, which increases the intracranial pressure, perifocal edema, and is caused by the changes in glial cell distribution. So this is the figure 2. High-grade glioma structure on T1CE, T2, and flare contrast. Images from left to right. Red circle is the necrotic core, and the blue circle is perifocal edema. So the location and histological subtype, and also the tumor margins are just a few of the variables that affect a brain tumor prognosis. Even after treatment, the tumor frequently returns and advances to grade 4-3. The site of the tumor can be determined using contemporary imaging techniques like MRI, which is then utilized to investigate tumor progression and arrange surgical procedures. Along with this, hemodynamics, MR imaging is used to evaluate the anatomy, physiology, and metabolic activity of the lesion. As a result, MR imaging continues to be the major method for diagnosing brain tumors. Early cancer identification in particular has the potential to alter how a patient is treated. Early detection is essential because lesions that are detected earlier are more likely to be treatable if action is taken. So this might be the difference between life and death. By prioritizing only malignant lesions, deep learning techniques might lessen the strain of radiologists reading numerous images and assist in automating the process of finding and classifying brain lesions. These can decrease diagnostic errors and eventually increase overall efficiency. Recent research has demonstrated that deep learning techniques in radiography have already surpassed human performance level for some pathologies. So recently, a number of deep learning based approaches for classifying brain tumors have been presented. T1 contrast enhanced images were used by Mugozi et al. To suggest a method for classifying high grade and low grade gliomas. So we performed a similar study on classification of gliomas based on grading, segmenting the tumor first before classifying it as either HGG or LGG. The majority of the literature on the classification and grading of glioma tumors employed a single MRI contrast image at a time. However, GET et al. Has used a fusion framework that simultaneously classifies the tumor using T1 contrast, enhanced T2, and flare images. The non-subsampled shear-lit transform, NSST, was used by another researcher to transform T1 images into low frequency, that is LF, and high frequency is HF. So sub-images effectively separating principal information from edge information in the source image. The images were then fused according to predefined rules to include the coefficients, resulting in the fusion of T1 and T2 or flare images. The majority of the literature simply distinguishes between the various grade of tumor and does not include healthy brain as a separate category. So one of the most effective network topologies for image identification task that was RESNet, or it is also known as a residual network, that was proposed by HEET et al. And addresses issues with deep network, such as disappearing gradients. So the identify mappings known as residual links or skipped connections that are introduced in this study. Their outputs are appended to the output of their stack layers. The identification links enhance the training process without increasing network complexity. The spatio-temporal models for action recognition are essentially 3D convolutional neural network built on RESNet. Video data is 3-dimensional since it has 2 spatial dimensions and 1 time dimension. So it is clear that utilizing a network with 3D convolution layer is the best option for processing such data, such as an action detection task. RESNet 2+1D and RESNet mixed convolution are 2 different types of spatio-temporal models that are introduced. In the RESNet 2+1D model, 2D and 1D convolutions are employed, with the 2D convolution being used for spatial component and 1D convolution being saved for the temporal component. By utilizing non-linear rectification, this provides an advantage of greater linearity and mixed type of mixed model more learnable than traditional complete 3D models. So the RES net mixed convolution model, on the other hand, is built using a combination of 2D and 3D convolution process. So the model's first layer are constructed using 3D convolution techniques, whereas its subsequent layers use 2D convolutions. The justification for this setup is that since most motion modeling takes place in the first few layers using 3D convolution, there better captures activity. Transfer learning is a method widely employed to boost the performance of the same network architecture, in addition to trying to enhance the architecture itself. So this method allows you to use a model that has already been trained to perform one task to perform another task entirely. Before beginning the training, the model parameters are typically initialized at random. Transfer learning, on the other hand, trains the model for task 2 using model parameters learned from task 1 as a starting point, referred to pre-training, rather than random values. Pre-training has proven to be a useful technique for enhancing the initial training process, ultimately leading to higher accuracy. So the contribution for 3-dimensional video classification applications, spatio-temporal models are frequently employed. Their potential for identifying spatio-spatial models such as 3D volumetric pictures like MRIs has not yet been investigated. This examines the potential for using the spatio-temporal models RESNet 2+1D and RESNet mixed convolution as spatio-spatial models by treating the slice dimension of the 3-dimensional volumetric pictures differently from the other 2 spatial dimensions. So basically, using a single MR contrast, spatial was used to classify brain tumors of various glioma types based on the grade, as well as healthy brain from 3D volumetric MR images. So their performances were compared to a pure 3D convolutional model, RESNet 3D. These models will also be contrasted with and without pre-training in order to assess the usefulness of transfer learning for this purpose. So the methodology. The network model utilized in this study are covered in detail in this section, along with implementation information, pre-training and training methodologies, data augmentation approaches, dataset details, data pre-processing procedures, and evaluation metrics. So quickly moving to network models. So for the task, using video where there are 2 spatial and 1 temporal dimension, spatio-temporal models are typically used. These models, as opposed to pure 3D convolution-based models, handle the spatial and temporal dimension in various ways. A 3D convolution-based model is frequently used since 3D volumetric image classification tasks lack a time component. They are occasionally cut into 2D slices and subjected to 2D convolution-based models in order to make the convolution kernels invariant to tissue discrimination in all dimensions and learn more complicated characteristics across voxels. So 3D filters are used for the purpose of classifying tumors. 2D convolution filter will be used to capture the spatial representation within the slices. So the spatio-temporal models can either reduce the complexity of the model or provide more non-linearity by combining 2 different forms of convolution into one model. So to consider the spatio-temporal models as spatio-spatial models in order to take use of these benefits while working with volumetric data, this is the rationale for utilizing such a model for a tumor classification task. So in this study, in plane dimension are taken as the spatial dimensions, while slice dimension is treated as the pseudo-temporal dimension of spatio-temporal models. So the work of Tran et al. Served as the foundation for the spatio-temporal models used here as spatial models. So RESNet 2+1D and RESNet mixed convolution are 2 alternative spatio-spatial models that are investigated in this article. So their performances are contrasted with RESNet 3D, a model that only uses 3D convolutions. So what is RESNet and 2+1D model? So instead of using a single 3D convolution, RES Net 2 plus 1D uses a combination of 2D convolution and 1D convolution. So as opposed to employing a single 3D convolution, this setup has the advantage of allowing an additional non-linear activation unit between the two convolutions. So the network overall number of RELU units that rises as a result, enabling the model to learn even more complicated functions. So RES Net 2 plus 1D employs a stem that consists of first D convolution with a kernel size of 3 and a stride of 1, followed by a 2D convolution with a kernel size of 7 and a stride of 2, receiving one channel as an input and producing 45 channels as output. So the following set of blocks include 4 convolutional blocks, each of which has 2 sets of fundamental residual blocks. So therefore a 3D batch normalization layer followed by a RELU activation function follows each convolutional layer in the model, both 2D and 1D versions. So to downsample, the input by half pair of 3D convolution layer with a kernel size of 1 and a stride of 2 are used to separate the residual blocks inside the convolutional block, with the exception of the first convolutional block. So basically, the 2D convolutions are applied in plane. An adaptive average pooling layer with an output size of 1 for all 3 dimensions has been introduced after the last convolutional block. After the pooling layer, a dropout layer followed by fully connected layer, that is n output neurons for n classes, were added to obtain the final output. So I will show you in the figure 3 that will portray the systematic diagram of RES Net 2 plus 1D architecture. So moving to RES Net Mixed Convolution, a combination of 2D and 3D convolutions are used in RES Net Mixed Convolution. This model stem include a 3D convolutional layer with a kernel size of 377 as stride or 122 and a padding of 133, where the first dimension is the slice dimension and the other 2 are in the plane dimension. So this layer accepts a single channel as input and outputs of 64 channels. So 3 2D convolution blocks come after the stem and then one 3D convolution block. All layers, both 3D and 2D, share the same kernel size and 1 stride parameters. Each of these residual blocks has 2 convolution layers, and each of these convolution blocks has 2 residual blocks. Similar to RES Net 2 plus 1D, a set of 3D convolution layer with a kernel size of 1 and stride of 2 are used to divide the residual blocks inside the convolutional block, with the exception of first convolutional block to downsample the input by half. A 3D batch normalization layer and a RELU activation function are placed after each convolutional layer in the model of both 3D and 2D. So the final pooling dropout and fully connected layers follow the convolutional blocks and are the same as those in RES Net 2 plus 1D architecture. So this is the figure 3, and that will show you the systematic representation of the model which was discussed, like RES Net Mixed Convolution. So you can see in the figure A, that is RES Net 2 plus 1D. Figure B is RES Net Mixed Convolution, and figure C is RES Net 3D. So these are the representations of network architectures which was built, and you can see in the first block, first out block, that is convolutional block and stem. Same in the second and same followed by the third. So now moving to RES Net Mixed Convolution. A combination of 2D and 3D convolutions are used in RES Net Mixed Convolution. This model stem includes the 3D convolution layer with a kernel size of 377, a stride of 122, and a padding of 133, where the first dimension is the slice dimension and other 2 are in plane dimensions, as the same as the first one. This layer accepts a single channel as input and output 64 channels. So basically, to conclude, the rationale behind utilizing both 2D and 3D mode of convolutional is that although 2D can learn representation inside each 2D slice, 3D filter and can learn the spatial properties of the tumor in 3D space. So it helps in learning tumor in 3D ways. So the final pooling, dropout, and fully connected layers follow the convolutional block and the same as those in RESNet 2+1D architecture. So RESNet 3D, a pure 3D RESNet model is used as benchmark to compare the performance of spatial models against against the C, with the exception of fact that this model exclusively employs 3D convolutions. So the net 3D model design is nearly identical to that next Net Mixed Convolution to see network model section. The main variation between these models stems from the usage of 4 3D convolution block in this model, as opposed to 1 3D convolution block, followed by 3 2D convolutional block in RESNet Mixed Convolution. A 3D RESNet 18 model is created using this RESNet 3D architectural setup. So the summary and the comparison. The input proceeds to the stem followed by those 4 convolutional block. First one, the output block, which is an adaptive pooling layer, then a dropout layer, and lastly a fully connected layer. This is the overall structure of network models. So the stem of RESNet Mixed Convolution and RESNet 3D is identical and consists of a 3D convolutional layer with a kernel size of 377, a batch normalization layer, and ReLU. So RESNet 2+1D that employs a distinct stem that consists of 2D convolutional layer with a kernel size of 7. So it is followed by a first deconvolutional layer with a kernel size of 3, separating the 3D convolution 377 used by the other model into a pair of 2D and 1D convolutional layers. So a batch normalization layer and a ReLU pair are followed by both 2D and 1D convolutional inside of this stem. So the convolutional blocks in RESNet 3D and RESNet Mixed Convolution designs have the same structure. 2 residual blocks made of 2 subblocks, each of which has 3D convolutional with a 3 kernel size, followed by a batch normalization layer and a ReLU. So by concluding this, the second, third, and the fourth convolutional block that were all contained a downsampling pair, which was composed of a 3D convolutional layer with a size of 1 and a stride of 2, followed by batch normalization layer. So this downsampling pair was included in the first convolutional block, but not in the other 3 blocks that are applicable to all the 3 models. So in the first convolutional block, this is absent. The number of input features to the first block is 64, while the number of output features to the fourth and final block is 512. So the convolutional block of each of 3 models double the input features by 2. So in the last stage of each of these models, an adaptive average pooling layer imposes 1 into 1 into 1 output formed with 512 distinct features. So a dropout with a probability of 0.3 is then applied to introduce regularization to prevent overfitting before supplying them to a fully connected linear layer that generate n classes as output. So the width and depth of these models are comparable, but they differ in terms of number of trainable parameters depending upon type of convolution used. So it is noteworthy that less the number of trainable parameters, the less the computational cost. So a model with a lesser number of parameters would require lesser memory for computation, GPU and RAM, and also the complexity of the model is lesser. So reducing the overall computational cost for both training and interference. Moreover, a lesser number of trainable parameters would also reduce the risk of overfitting. You can find the data of these all models in the research paper. I provided link in the chat box before. You can find the paper there. As separating healthy brain from brains with pathology is in comparison a simpler task than determining the grade of the tumor. All of the models F1 scores are classifying healthy brain were extremely close to 1. So furthermore, MRI may have caused a dataset bias with implying 2 distinct datasets for healthy and a sick brain. So the pre-trained RESNet mixed convolution model fared best at grading tumor, whereas all 3 pre-trained models performed similarly at grading healthy brains. So macro and weighted F1 scores were utilized to compare the model based on aggregated scores. However, because the dataset was unbalanced, the macro F1 scores should be given more weight. Both of the metrics declared the pre-trained RESNet mixed convolution as the clear winner, The classification performance of the models for the LGG class has been less successful than the other two classes, which is an intriguing finding form. So the confusion matrices. So even the top model could only achieve accuracy of 81% for LGG and 96% for HGG, and almost perfect results for healthy. This could be explained by the dataset extreme imbalance, which included 259 volumes for HGG and healthy, while only having 73 volumes for LGG. So you can find the data as I mentioned in the paper. It would be long, so I couldn't include in this presentation. Even though weighted cross entropy loss, that is weighted cross entropy loss section, was used in this research to deal with the problem of class imbalance, increasing the number of LGG samples or employing further techniques to deal with this problem further and might improve the performance of the models for LGG. So notably, despite having the fewest trainable parameters of any model, the pre-trained RES Net Mixed Convolution produced the best classification performance. It should also be highlighted that both spatial models outperformed the pure 3D RES Net 18 model, despite the fact that they had less trainable parameters. Still, less trainable parameters can result in lower computational cost and a lower likelihood of overfitting. So the increase in non-linearity brought about by additional activation functions between the 2D and 1D convolutions in the 2+1D convolutional layer, according to me, that helped the RESNet 2+1D model outperform RESNet 3D and reduction of trainable parameters, while maintaining the same number of layers had the RESNet mixed convolution model that was succeeded. So the spatial relationship between the three dimensions is not preserved within the network, like a fully 3D network as RESNet 3D, which is a limitation of this architecture and maybe have some unanticipated negative effect. Despite the fact that the spatial models perform better, it is important to note that they do not adequately maintain the 3D nature of the data. So I proposed that this relationship was indirectly maintained through the network channels, and that the network might pick up on the general representation in order to make the proper classifications. So the trials have additionally demonstrated that for presented brain tumor classification challenge, spatial models outperform completely 3D models. Nevertheless, these models need to be further tested for various tasks before a general agreement is reached regarding this finding. In this research, they specially treated spatial dimension of spatial models, which can alternatively be thought as a pseudo-temporal dimension of the spatio-temporal models was assumed to be the sliced dimension in the axial direction. So it has still to be proven, but whether it is also possible to utilize the benefits of such models by similarly orienting the data in sagittal or coronal orientation, according to the author premise. Additionally, it was found that the pre-trained models took first place in each of the three classes. Pre-training had a different impact on each of the three models, though pre-training enhanced the performance of models for both spatial models, although to varying degrees like 2.24% for RESNet 2+1D and 8.57% for RESNet mixed convolution that was based on macro F1 scores. Pre-training, however, adversely affected the 3D res net 18 model that was for 2 out of 3 classes, resulting in only 1.87%. That was the reduction in the macro F1 score. The pre-training led to an overall improvement of 2.88% across all models, as seen by the average macro F1 scores for all the model without pre-training. That was 0.9169 with pre-training and 0.8912 without pre-training. So the fact that the pre-trained networks were first trained on RGB videos is important. The performance of model might be enhanced by pre-training them using MRI volumes or MR films, dynamic MRIs. Regarding comparisons to other research that have been published, it's interesting to note that those earlier papers simply categorized distinct grades of brain tumors, LGG and HGG, whereas this paper additionally added a class for healthy brains. As more classes make the task harder, the outcomes are therefore not entirely comparable. Even so, the results of the winning model are superior to all previously published techniques, with the exception of one that showed outcomes that were on par with RES Net Mixed Convolution. That paper reported 0.12% better accuracy and 0.41 less specificity. However, this paper used 4 different contrasts and an additional data set apart from BRATS, making them have a larger data set for training. So these were the few images from the research and from the hospital and the participants who was treated and whose tumor was located through this model. So finally reaching to the conclusion, this research confirms how RES Net 2+1D and RES Net mixed convolution acting as spatio-spatial model that might enhance the classification of brain tumor grade, that is low grade and high grade gliomas, as well as classifying brain pictures with and without tumor, while lowering the computing cost. The performance of spatio-spatial model was compared to a pure 3D convolution model using a 3D RESNet 18 model. To examine the efficacy of pre-training in this configuration, each of the 3 models was trained from scratch as well as using weight from pre-trained models that were trained on an action recognition dataset. So threefold cross-validation was used to produce the final result. Despite having fewer trainable parameters, it was found that the spatio-spatial models outperformed a pure 3D convolutional RESNet 18 model in terms of performance. So further observation reveals that pre-training enhanced the model functionality. Overall, the pre-trained RESNet mixed convolution model was shown to be the best model in terms of F1 score, attaining 0.8949 and 0.9123 F1 score for low-grade glioma and high-grade glioma, respectively, and a macro F1 score of 0.9345 and a mean test accuracy of 96.98%. So overall, this research demonstrates the potential of spatio-spatial models to outperform a fully 3D convolutional model. This was demonstrated here, however, only for a specific job of classifying brain tumor using the dataset BRATS. This model should be compared for other tasks in future to build a common consensus images for classifying the tumors, which already resulted in good accuracy, incorporating all 4 available types of images, T1, T1CE, T2, and T2 flare, or any combination of them that might improve the performance of the model even further. So you can find this paper in International Journal Dental and Medical Science Research. So in volume 4 and issue 4, you can also visit my ResearchGate ID and you can even find the paper there. This is my ResearchGate ID. You can connect with me in this Instagram ID. Thank you. Thank you.
Yeah, thank you so much, Dr. Dahal, for throwing the light on the title of the event.
You're welcome.
Yeah, I'm sure everyone will agree with me that it was quite knowledge giving. Okay, so any questions or any topic of discussions from any of our attendees here?
Yeah.
Yes, Dr. Bhati.
Yeah, Tshetiz, it was an excellent presentation. We have learned that, T1 contrast, with the T1 contrast alone, you have done that. But along with that, if other parameters have been taken into consideration, things must have changed, right? And moreover, I just wanted to know, in flare images or the T1 images without contrast, the actual description of the tumor cannot be ascertained in low grade gliomas, LGG basically. What do you say about this, Dr. Tshetiz? That may be a difficult task if you don't take purely T1 contrast images. You must have come across, right?
Yeah, but you can use the RESNet 2+1D because that employs a combination of 2D convolution and 1D
And the
convolution.
things. Right.
Yeah, so it is a 3D patch normalization layer. So that
Right.
will be followed by RDLU activation function. That will also both used for 2D and 1D versions. So it is basically good for the question you asked. It's a very good question. So the last convolutional block can also be used, and a pooling layer, a dropout layer. So that can be followed by fully connected layer. That will be an output neuron. So basically the end classes.
Absolutely. As a neurosurgeon, I'm actually practicing at Apollo Hospital, New Delhi. For the last 8 years, I've been into this surgery part. So we've been doing this deep-seated tumors and everything. And this part can be helpful to us in, exact spatial localization and everything.
Yeah, you can find the every data set in the paper I provided. I provided the link in the chat box before.
Now, I was going through that actually.
Yeah, you can find it there.
Yeah, yeah.
It was very nice talking to you.
Same here, Dr. Tshetiz. Same here.
Thank you.
Thank you.
Yeah, it was a great interaction. We just